Have you ever, really thought about your body's hidden microscopic drainage system?
Oh, most people haven't. It's completely invisible until it fails.
Right. I mean, just imagine this massive, incredibly complex network working around the clock right under your skin.
Hmm.
Its entire job is silently clearing out protein-rich fluid, cellular waste, and, immune byproducts from your tissues.
Yeah. And think about what happens when that vital system suddenly hits a roadblock. The fluid just keeps coming, but the drain is permanently plugged.
It's a devastating clinical scenario. I mean, in healthy tissue, your venous system handles most of the fluid return, sure. But the lymphatic system, that picks up the heavy lifting, the large proteins, the remaining interstitial fluid.
Exactly. And when the transport capacity of that lymphatic system is exceeded, you get lymphedema. We're not just talking about a little minor end-of-the-day swelling here.
No, absolutely not. So today, our mission for this deep dive is to explore the clinical reality of lymphedema. We're going to look at exactly why it happens, the critical nuances of diagnosing it in your clinic, and the fascinating evolution of treatments.
Yeah, tracking the journey all the way from the basic physics of heavy compression bandages to cutting-edge super microsurgery.
Okay, let's unpack this, because we need to start with the sheer scale of the problem.
Right, the clinical context here is staggering. In the United States alone, we're looking at an estimated 3 to 5 million people suffering from this condition right now.
3 to 5 million, that is a massive patient population. And how many new cases are we talking about each year?
Up to 50,000 new cases are diagnosed annually.
Wow.
And it is a severe quality of life issue. Patients are dealing with recurrent, really dangerous infections like cellulitis. They deal with severe disfigurement, chronic pain, and, as we'll discuss later, even highly aggressive secondary malignancies.
So to figure out how to actually treat this, we first have to understand exactly why the plumbing backs up in the first place.
Yeah, you have to know the mechanics.
Right. So think of the lymphatic system like a city storm drain system during a hurricane. When the transport capacity is exceeded by the sheer volume of rain, the water has nowhere to go. It just spills out into the streets.
That's a great way to visualize it.
Yeah, and in the body, that interstitial fluid spills out into the surrounding tissues. And a quick aside here, medical terminology is notoriously tricky, right? Just like the plastic surgery term prophytosis is pronounced apophasis, lymphedema comes with its own dense clinical vocabulary.
It really does. But that storm drain analogy is perfect. Clinically, we divide these drainage failures into two main categories, right? Primary and secondary lymphedema.
Let's start with primary.
Okay, so primary cases are developmental abnormalities.
Yeah.
This is where the storm drains were built incorrectly from the very start. There are three main types you'll encounter. First is present at birth, right? Clinically evident right out of the gate. It accounts for about 2% of congenital lymphedema cases, and it follows a familial, sex-linked pattern of inheritance.
I know this one comes down to a very specific genetic glitch. It's an issue with a receptor, isn't it?
Correct. It's linked to a loss-of-function mutation in the vascular endothelial growth factor 3 receptor, or VEGF3.
VEGF3, yeah.
Yeah, think of that receptor as the master blueprint manager for your lymphatic pipes. When there's mutation there, the blueprint gets smudged. As a result, the lymphatic channels end up hypoplastic.
Meaning they're just too small.
Exactly. Severely underdeveloped and physically too small to handle the daily fluid load.
But Milroy's is incredibly rare. The type of primary lymphedema that shows up most often in the clinic is lymphedema precoxia.
By far the most common. It accounts for 65 to 80% of all primary cases.
And when does that usually show up?
It typically presents as unilateral lymphedema, so swelling in just one arm or leg starting before age 35. Usually it triggers right around puberty, and clinically you'll see females affected 4 times as often as males.
Wow, 4 times. And what's happening to the pipes and precox?
In these patients, the functional lymphatics are drastically reduced in both caliber and number.
Okay, and then you have the late onset version, lymphedema tarda.
Right, tarda manifests after age 35. It's relatively rare, making up only about 10% of primary cases. It mostly affects the lower extremities, and again, it's more common in women.
And the genetic link there is different, right?
Yeah, we often see loss-of-function mutations in the FOXC2 gene here. But the histology is what's really unique. Instead of reduced or tiny channels, you actually see hyperplastic, highly tortuous lymphatics.
Wait, really? So the pipes are actually larger than normal?
Yes, the pipes are large, but the backflow valves inside them are entirely incompetent or completely absent.
Oh, I see. So the fluid just pools. So primary lymphedema is a factory defect. The plumbing was bad from day one. That brings us to secondary lymphedema.
Acquired dysfunction.
Right. The plumbing was built perfectly fine, but something came along and destroyed it. In the U.S., this is overwhelmingly a consequence of cancer treatment or trauma.
It's the most common cause in Western countries, with breast cancer patients making up the largest group. I mean, think about the surgical reality of cancer treatment. We are physically removing the lymph nodes that drain the arm.
Which has a massive impact.
Huge. As many as 50% of patients who undergo an axillary lymph node dissection will develop lymphedema. Even with a less invasive sentinel lymph node biopsy, 4 to 7% will still develop it.
And it's not just breast cancer, is it?
Not at all. You have a roughly 30% risk in sarcoma patients, 20% in gynecological malignancies, and 16% in melanoma patients. Plus, the radiation therapy we use, well, it causes severe fibrosis. It essentially scars down the delicate lymphatic vessels until they choke off.
But if we zoom out from the U.S., the global picture completely shifts. It's not surgery causing the most damage worldwide.
No, it's not. What's fascinating here is the sheer scale of infectious lymphedema globally. We're talking about filariasis.
Which is caused by a parasite, right?
Yes, a parasitic nematode, the filarial worm Wuchereria bancrofti. It's transmitted by mosquito bites, and it affects an astonishing 140 to 250 million people worldwide.
That is just mind-blowing. How does a worm cause a plumbing failure, though?
The microscopic larvae migrate straight to the lymphatic vessels and mature into adult worms. They literally nest inside the lymph nodes and channels.
Oh, wow.
Yeah. This invasion triggers massive immune inflammation, progressive fibrosis of the vessels, and eventually lymphedema of epic proportions. The fluid backs up so severely it transforms the architecture of the limb.
It's a staggering global health crisis. So knowing all these underlying causes, from missing valves to parasitic worms, is one thing. But how do clinicians actually measure and confirm this backed up grain in a live patient, without causing more damage?
That's the daily clinical challenge. Diagnosis starts with a meticulous clinical history and physical exam. Patients report subjective feelings. First, skin tightness, a heavy feeling in the limb, severe joint fatigue.
And then you move to objective measurements.
Right. And the standard objective metric for a long time has just been a tape measure. We take limb circumference or volume measurements.
See, I have to completely push back on that standard metric. If lymphedema is officially considered a difference in limb measurement of greater than 2 centimeters, isn't that inherently flawed?
How so?
I mean, think about it in real life. A 2-centimeter increase on a frail 90-pound patient is drastically different from a 2-centimeter increase on a morbidly obese patient. You're comparing apples and oranges.
You're absolutely right, and it's a huge clinical pitfall, the highly relative grading scheme. Inter-examiner variability is a massive problem. Honestly, a 2-centimeter difference might just come down to how tight the resident pulled the tape measure that afternoon.
Exactly.
That's why modern clinics use objective, non-invasive tools to combat that exact variability.
What are the go-to tools for that kind of precision now?
Spirometry is a great one. It uses infrared scanning technology to estimate limb cross-sectional diameters at multiple intervals. You get an incredibly precise 3D model of the limb volume. We also lean heavily on bioimpedance spectroscopy.
How does bioimpedance actually figure out if there's trapped fluid?
It measures the rate of electrical current transmission through the tissues. It's basic physics. Water conducts electricity much faster than fat or healthy tissue.
Right, of course.
So by running a tiny painless current through the limb, the machine calculates the exact extracellular fluid content of the swollen limb and compares it to the normal limb. It is incredibly sensitive for early-stage detection, way before a tape measure would catch it.
And what about looking inside the limb? What imaging are we using?
MRI and CT are heavily utilized. On both of these modalities, advanced lymphedema presents with a very distinct subcutaneous honeycomb pattern.
Honeycomb. What exactly creates that look?
You're seeing the fat lobules in the tissue completely separated by thick bands of trapped, stagnant fluid and fibrotic tissue. It literally looks like a honeycomb. Ultrasound is also a fantastic bedside tool to correlate subcutaneous tissue thickness with the progression of fibrosis.
Here's where it gets really interesting, because the stakes of misdiagnosis or ignoring long-standing lymphedema go way beyond just a swollen limb. There is a lethal, catastrophic complication we have to discuss.
Yeah, you're talking about Stewart-Treves syndrome.
Right.
It was first reported by Dr. Stewart-Treves back in 1948 in patients dealing with severe post-mastectomy lymphedema. This is a highly aggressive lymphangiosarcoma, a cancer of the lymphatic vessels themselves that develops entirely in the setting of chronic, long-standing lymphedema.
But why does trapped fluid suddenly trigger a sarcoma? That seems like such a leap.
It comes down to a localized failure of the immune system. The chronic fluid buildup creates an immunologically privileged site.
Meaning the immune cells just can't get in there.
Exactly. The immune cells that normally patrol for malignant changes simply can't function in that stagnant fibrotic swamp. The cells mutate, and the cancer takes hold.
How does it present clinically? Like, what are we actually looking for?
Patients present with these rapidly growing red or purple macular nodules popping up within the diseased, chronically swollen tissues.
And the prognosis is bad, right?
It's grim. The 5-year survival rate is less than 10%. Even with highly aggressive surgical management, which usually means radical amputation of the affected limb, the average survival after diagnosis is only 19 months.
That is terrifying. It really underscores why we can't just ignore the fluid buildup. It's not just a cosmetic issue, it's a ticking clock.
Absolutely.
So once a patient is diagnosed and properly staged, how do we fight the flood?
Well, we stage it from stage 0, which is latent impaired fluid transport with no visible swelling yet, all the way to stage 3, which is lymphostatic elephantiasis.
And stage 3 is the extreme end.
Yeah, stage 3 involves severe swelling, severe adiposity, and hyperkeratosis.
Explain hyperkeratosis in this context. Why does the skin change so drastically?
Because the trapped interstitial fluid isn't just water, it's extremely protein-rich. When those proteins sit in the tissue, they trigger a massive chronic inflammatory cascade.
Fibroblasts move in, I'm guessing.
Yep, they move in and lay down dense scar tissue. The skin reacts by thickening immensely, becoming scaly, hard, and almost woody. It totally loses its elasticity. But despite how bad it looks, the immediate goal is almost never to cut. The absolute first line of defense is conservative management.
Right, so we're talking about managing the physical fluid pressure.
Exactly. Complex Decongestive Therapy, or CDT, is the gold standard. It's designed to physically squeeze the fluid volume out of those tissues.
How does CDT actually work in practice?
It has 2 distinct phases. Phase 1 is intense. Patients come to the clinic once or twice a day for 4 to 6 weeks. They undergo manual lymphatic drainage.
Like a massage.
Well, it's not a deep tissue massage. It's a very specific, light stroke skin stretch that stimulates the remaining lymphatic vessels to pump. They also get specialized skin care, light exercises, and intense compression wraps.
Let me ask a practical question here. The clinical texts always specify short stretch bandages for those wraps. Why specifically short stretch? If I want to compress an arm, why not just use a standard, highly elastic drugstore bandage?
It comes down to clinical physics. You have to understand resting pressure versus working pressure.
Okay, break that down.
Short stretch bandages have very little give. They maintain a constant, low, safe pressure while the limb is just resting. But when the patient stands up or exercises, the muscle flexes and expands against that rigid bandage.
And because it doesn't give.
Right, because the short stretch material doesn't give way, it creates a high working pressure, driving the fluid out of the limb like a pump.
And the high stretch bandages do the opposite.
Yeah, high stretch bandages, like a standard ACE wrap, they want to shrink back to their original size. They exert a very high pressure at rest. If a patient leaves a high stretch bandage on while sleeping, that constant high resting pressure acts like a tourniquet.
Wow, so it can actually be dangerous.
Highly dangerous. It can cause circulatory compromise. You can literally cut off the arterial blood supply to the limb.
That is a critical clinical pitfall. You also mentioned exercise earlier. That represents a huge paradigm shift in lymphedema care, right? Because for decades, patients were strictly told to avoid any vigorous exercise with the affected limb.
Oh, they were told to treat the limb like glass. The old theory was that exercise increases arterial blood flow, which in turn would increase the interstitial fluid load, overwhelming the broken pipes and making the edema much worse.
But that's not true.
No, it turned out to be completely wrong. Multiple prospective clinical studies have now definitively proven that progressive, monitored exercise regimens are highly beneficial.
Why does it work instead of hurting them?
If we connect this to the bigger picture, the muscle acts as a motor. The muscular pump mechanism literally acts as an internal engine. When the muscle contracts, it physically squeezes the remaining lymphatic vessels, propelling that trapped fluid out of the extremity.
That makes so much sense.
Plus, exercise promotes weight loss. We know for a fact that maintaining an ideal body weight independently decreases the incidence and severity of lymphedema flare-ups. Obesity is a massive compounding factor.
But let's be honest, CDT is exhausting. It's incredibly time-intensive, it's expensive, and it requires a highly trained, certified lymphedema therapist. Insurance often fights covering long-term care.
It's a huge burden on the patient.
Yeah, and phase 2 of CDT is basically indefinite compression garment use. You have to wear tight, uncomfortable sleeves every single day. Patient non-compliance is predictably and, understandably high. Conservative management is a lifelong heavy burden. When it fails or when patients just can't tolerate the garments anymore, the surgeons step in. So what does this all mean?
It means we have to look closely at our surgical options. And the surgical frontier here has evolved drastically. We used to rely entirely on reductive methods, basically, brute force removal of the diseased tissue. Now, we're moving aggressively toward physiological methods that actually attempt to rewire the microscopic plumbing itself.
Let's start with the brute force methods. Paint a picture of what we're looking at there.
The classic historical example is the Charles procedure, described over a century ago. This is strictly a salvage operation for extreme end-stage cases.
What does it involve?
It involves a massive circumferential excision of the skin and subcutaneous tissue all the way down to the deep fascia. You're literally filleting the diseased tissue right off the leg. Then you resurface the bare exposed muscle with the skin grafts taken from the discarded tissue.
That sounds incredibly brutal and invasive.
Highly invasive. It carries massive morbidity. We're talking severe pain, terrible cosmetic outcomes, chronic wound healing complications, massive infections, and lymph fistulas where fluid just leaks constantly.
Good Lord.
In some severe cases, the complications from a Charles procedure are so bad they eventually lead to limb amputation anyway. It's an absolute last resort.
A more modern, elegant, reductive method is liposuction, right? But there is a massive clinical caveat here that patients need to understand.
Right. Liposuction uses a cannula to aspirate the pathologically generated fibrofatty tissue. It is highly effective for reducing sheer limb volume in non-pitting lymphedema. It's particularly useful in the upper extremity after breast cancer treatment.
How much volume are we talking?
We are talking about successfully removing volumes where there is at least a 600 cc difference compared to the healthy limb.
But here is the common pitfall. Liposuction forcefully removes the fat, but it does absolutely nothing to fix the underlying plumbing issue.
Exactly.
The lymphatic transport capacity is still broken. The pipes are still clogged.
That is the crucial point for any clinician to remember. Liposuction is a volume reduction. It is not a cure. If a patient gets liposuction for lymphedema and then decides they don't want to wear their compression garments post-op, the entire procedure was a waste of time.
Because the fluid just comes back.
Rapidly, all that interstitial fluid and reactive fatty tissue will reaccumulate. Within just one single year, they are right back where they started. Continuous, lifelong compression therapy is 100% mandatory after liposuction.
That brings us to the physiological methods. This is the real frontier. Instead of just debulking the limb and hoping for the best, surgeons are actually trying to fix the broken pipes.
Yes. The most prominent procedure right now is the lymphaticovenous bypass.
Okay.
This relies on incredibly advanced supramicrosurgical techniques. The surgeon locates the obstructed collecting lymphatic vessels and physically sutures them directly into nearby subdermal veins.
So you're creating a literal detour.
Exactly. You're bypassing the lymphatic blockage in the armpit or the groin and dumping the lymphatic fluid right back into the venous system where it belongs.
Super microsurgery. We're talking about suturing vessels that are less than a millimeter wide. How does a surgeon even find a functional, tiny lymphatic vessel hidden inside a massively swollen fibrotic arm?
That was the main technical hurdle for years. Operating blindly in that tissue is a nightmare. But the absolute technological game changer has been indocyanine green, or ICG, fluorescent lymphography.
It's an incredible piece of tech. How does it work in the OR?
You injected a tiny amount of the ICG dye into the web spaces of the fingers or toes. The dye physically binds to the proteins in the lymphatic fluid. Then you shine a near-infrared camera over the skin.
And it glows.
Right. It literally glows bright green right through the patient's skin before you ever make a single scalpel incision. You can trace the exact flow of the fluid, see exactly where the functional pipes are located, and map out your venous bypass perfectly.
And the clinical outcomes are shifting dramatically because of this precision. Recent studies looking at lymphaticovenous bypass in breast cancer patients are showing incredible results. Over 95% of patients reported subjective symptom improvement, with a mean limb volume reduction holding steady around 35% at a year out.
And the complication rates are phenomenally low, mostly just minor wound healing issues or a temporary bout of cellulitis. Nothing like the Charles procedure. This raises an important question. If we can find these vessels with ICG, and we can bypass them effectively with supramicrosurgery, why wait until the patient develops irreversible fibrofatty tissue changes?
You're talking about preventative surgery, fixing the plumbing before it ever has a chance to back up?
Exactly. This is known as the LIMPHA approach.
Yeah.
There's a groundbreaking prospective randomized clinical trial looking at this very concept.
What did they do?
Surgeons performed a lymphovenous bypass at the exact time of the initial axillary lymph node dissection. So while the surgical oncologist is removing the cancerous nodes and inherently damaging the pipes, the plastic surgeon steps in immediately and rewires the lymphatic channels prophylactically right then and there.
And the numbers from that trial are incredible. The incidence of lymphedema in that group dropped from 30.4% down to just 4.3% at 18 months.
It's a massive practice-changing reduction. Now, we always interpret early results with scientific caution, of course. It was a smaller trial, and the volume criteria they used was an increase of 100 cc's.
Which some people argue is too low.
Yeah, some critics argue that 100 cc's is within the standard error of measurement, as most larger studies prefer a stricter 200 cc threshold for diagnosis. But regardless of the threshold debate, the clinical proof of concept is absolutely there. The preventative bypass showed demonstrably increased transport capacity.
It's a completely different way of thinking about the disease. We are finally moving away from reactionary debulking to proactive physiological rewiring. So let's recap the main takeaways from today's deep dive. We started with the foundational anatomy, understanding the hidden plumbing and what happens when the venous system's backup fails. We looked at the genetic roots of primary conditions like Milroy's disease and how a smudged blueprint in the VEGF3 receptor leads to underdeveloped pipes.
From there, we covered the staggering scale of secondary lymphedema. We discussed the stark post-surgical realities of cancer treatment here in the U.S., contrasted against the massive global burden of filariasis and the inflammatory damage caused by parasitic worms.
Right.
We highlighted the real clinical danger of Stewart-Treves syndrome, how stagnant fluid invites aggressive malignancies, and we stressed the critical importance of using objective diagnostics like bioimpedance over highly flawed subjective TEAT measures.
And then we talked about the critical, everyday mechanics of complex decongestive therapy. The vital clinical physics of utilizing short-stretch bandages to create high working pressure, and the paradigm shift that proved the muscular pump of exercise is actually a lymphedema patient's best friend.
And finally, we tracked the surgical evolution. We've moved far away from the brutal, salvage nature of the Charles procedure, the strict lifelong compliance demands of liposuction. Instead, we've arrived at the supramicrosurgical frontier using ICG dye to map microscopic vessels and performing preventative lymphovenous bypasses to stop the disease before it ever truly starts.
It leaves you with a really provocative thought about where the field is going next. If surgeons are already rewiring microscopic lymphatic channels prophylactically at the exact time of cancer surgery, how far are we from utilizing targeted gene therapies? Think about it. If we can manipulate that exact VEGF3 receptor that we see causing primary lymphedema, could we eventually just regrow a patient's entire lymphatic system from scratch? We could theoretically turn a lifelong, heavily disfiguring chronic disease into a temporary, entirely curable inconvenience.
That really is the ultimate clinical goal, restoring true physiological function and rebuilding the network without needing to bypass anything at all.
Exactly. It's all about looking closer. Keep questioning the hidden mechanics of the human body, keep pushing for better diagnostic standards in your clinics, and never forget the incredibly complex microscopic systems working just under the surface. Until next time, keep exploring.